things as we get started, and people will be coming in as we are. But tonight we're talking about cognitive impairment and memory issues, and specifically how to understand this almost growing epidemic in our culture. And probably everybody knows somebody or just has a couple degrees of separation from somebody who has some type of cognitive impairment uh, through the aging process or through some type of injury or a disease process that may have caused that. And so we're going to talk through that and how to understand that better. Um, Throughout the lecture, if you decide that you'd like one of our the books for Forge Your Inner Armor, if you just type book in the chat, you'll receive a copy of that, a free copy of the book, and love to get that out to you. So just put that in the chat, okay? Put that in the chat if you want that, and we'll know who you are and send that to you. And then as we go through the lecture and you have questions, use the chat to type the question. I'm probably going to field those more at the end as we go, just so that I can get the information out, kind of lay the foundation for where we're going. And then as we get towards the end, I'll start taking some of those questions as they come. Okay? So again, you're putting the word book in if you'd like a book. And if you have questions along the way as we hit topics, just go ahead and put them in the chat. Okay? It's great to have you in here today. This is definitely a hot topic. We're all at some stage in our life wonder about, for ourselves personally, how strong our brain will be as we get older, or as we might be experiencing something that could be a disease process, or we have somebody close to us that we're wondering about how their brain is functioning. The thing about the brain, which I always have an extra one with me, thing about the brain is you only get one of them. Okay, there's a lot of things in our medical culture that we can change, fix, replace, but you really can't do anything in relation to the brain in changing it or replacing it. You get one that lasts you from birth through your lifetime. And so we want to make sure that we understand it first and that we take care of the way that we look at things is we see the brain as the ultimate upstream in everything that we do. It is the thing that interprets the environment for us. It's key in relationships, and it's a uh, necessary thing to all of our existence. There are things that the brain does for the body that makes the body work, which is in and of itself, the body, an amazing thing. And then the next thing downstream is all the things that we think about and feel. And then lastly are the behaviors, the things that we experience. And many times we get caught up in just looking at behaviors. This happens a lot in traditional medicine. You know, I can't sleep, or my blood pressure's off, or I have an issue with my blood sugar. And we chemically try to alter that behavior, or I'm depressed or anxious. And we're really good at chemistry, especially in the United States. The problem is many times we don't look upstream at the brain and how it's working. And we could actually do a disservice to the brain as an entity. So it's always important that we're looking upstream at the brain. And so in cognitive disorders, that's a particular one where it becomes pretty apparent over time that the brain is causing these different attention issues, memory issues, ability to control impulses and emotions. And so the better we understand the brain, the better off we are. So let's first look at a couple things here. Just to give you a visual image, okay, this is the visual image of a normal brain. This is a graphic, of course, and an Alzheimer brain. And what you see right off the bat is that they're definitely different in their size, their volume of the size of what's called the hippocampus, which is where you store a lot of memories in the hippocampus. Um, and a big one is the size of the white matter. The white matter, if you notice this in here, it looks a little tan, but the white matter is much less in an Alzheimer brain. And there's other things going on in relation to the ability for the Alzheimer brain to flush out toxins and amyloid plaques and all those different types of things. But from a presentation, one looks very healthy and one looks like it's not healthy. And that's what can happen to the brain over time as it experiences a cognitive disorder. We don't know all the reasons why this happens for some people and doesn't, but we do know ways to try to prevent some of these things going on. So let's talk about the different types of disorders, cognitive disorders, just to kind of put these things in things. We might use the word dementia to describe something when maybe it's more specific, or sometimes we'll use Alzheimer's to describe something that isn't really Alzheimer's, but it's related to something like Parkinson's or Huntington's disease, or something referred to as Lewy body, which has very similar to Parkinsonian things with some protein issues. But these are different reasons why people might have a cognitive disorder, where their memory gets impaired, where their attention is impaired, where their personality becomes blunted and they have difficulties with their personality. But it's not just one thing, it can be a variety of things. Different infections, like there's forms of cognitive disorders that can be brought on by HIV infection. Substance abuse can create different types of delirium and dementia. You may have heard that word delirium versus dementia. Delirium is more of a short-term type of thing that happens that can look a lot like dementia, but it's short-lived and it has some type of causal agent. Like if you put somebody in an environment where they lose perspective of night and day, this happens in hospitals many times, where somebody's not in a room where there's windows, they can experience a delirium where they start to lose touch with reality, they can't remember things, and it may look like a dementia, but it's really situationally based because of them losing their circadian rhythm. So you always want to distinguish right out of the chute the difference between a delirium, which can be brought about by environmental things or infections, versus a dementia, which is more of a slow process that happens over time. Okay. So here's where we start. Number one is you must address the rule outs. Could this be something else? Okay. And let me share an experience with you. I've been doing this for about 35 years, and all through the 90s, I did consultation for a lot of different hospitals, worked in uh, a bunch of different psychiatric facilities, inpatient psychiatric facilities, and I've seen a lot of things over the years as far as extreme psychiatric illness. But for about 6, 7 years, I worked for the local hospital on their psych med unit. And so a psych med unit is a place on a hospital, a floor on a hospital where somebody has a medical condition, but combined with that is also a psychiatric condition. So they can't really go to the psych hospital because they need the medical attention that occurs in a hospital. So you have a floor that might work as a kind of triage place to stabilize and then send the person either to the psych hospital or maybe back home for outpatient type things. Well, I was one of the neuropsychologists that was responsible to come in and help the psychiatrists figure out what these different disorders were. Because the psychiatrist is more of a medical doctor that's looking more at behaviors. They don't really have a lot of training or any training in formal testing. And so they're just kind of going through checklists. But a lot of times it's hard to differentiate, as you saw this list earlier, like what's causing the memory issues. And the first time I saw this was quite remarkable. And I remember coming in and I met with this lady, and it was full blown, to me, full blown dementia. I mean, could not remember anything. Personality was off, blunted affect, everything was like this person was full blown dementia. And I was going through the testing, and she came out with significant memory problems. And as I was going through the chart, I also noticed that she had a UTI. She had a urinary tract infection. And the psychiatrist said, "Yeah, we're going to go after that and just see what happens." And I said, "Well, my testing shows, I mean, at this moment in time, she's really having major cognitive issues." I came back a week later, and as I walked in the door, I saw somebody that looked like the lady I met with, but this person was fully dressed to, to the nines. Everything was, perfect. And she hadn't remembered my name, but she remembered my face and introduced herself. Hello. I'm like, this isn't even the same person. Like, what happened to this person? And what we discover, what I started to see over and over again through that experience is it's not always what you see on the surface. This person had an underlying infection that was causing their brain to look like something else. And so I want to put a few of these things in that you must rule out when you're before you make a diagnosis, even if testing or screening shows a memory issue. And the number one thing, and we're going to have a whole lecture about this topic in a couple months here, is what I refer to as the great imposter. Not me, excuse me. The literature over the years, decades, has called this disorder the great imposter, and that is depression. Depression hides itself in so many things. It hides itself in substance abuse, school failure, job loss, relational issues, personality disorders, and later in life, the great imposter can show itself looking a lot like depression or a lot like dementia. Um, you would be amazed how many people that I've seen over the years that next two dementia patients next to each other, and they look exactly the same. But through the right type of testing, we pick up a depressive disorder that's been there throughout their life, and we actually treat the depressive disorder. The one patient who truly does have dementia continues to decline over time, but the person that we actually treat, the underlying depression, starts to look totally different. And I've seen this over and over again, and this is things that's missed in most general practice settings, is that depression can come out in a lot of ways. And as we age, one of the places it comes out a lot is in memory impairment. The second thing which you heard me give that example about was the UTIs, any type of underlying infection we must be ruling out in somebody who's having. And you can have people that have ongoing, especially as individuals get older, ongoing UTIs that they go below the surface for a little bit, and then they come back up again, and then they go below the surface. And subsequently, their cognitive functioning does this. And it just looks like when they go into their doctor's office and answer a few questions that this person has dementia or cognitive disorder, when really there might be something else going on. Sleep disorder is another huge thing. So many times people miss that there's a lifetime of sleep issues going on that haven't been addressed. Some things like sleep apnea that go long term that aren't addressed that can look very much like dementia, but you start to treat the sleep apnea and all of a sudden it goes away. These are things that most general practice settings aren't going to be looking at. And then, this one's kind of pretty tough to swallow, but it's the truth is traditional medicine induced. So there's many things that we do in medicine or that can be done in medicine that are addressing the downstream behaviors or physiological things, and you miss the forest for the trees. Is you're looking at the immediate, but there's no exit strategy to the immediate. It's just, we'll just do this for the rest of your life. And in that process of taking that medicine that may be helpful for one thing, you can create other problems with the brain that introduce themselves. So let me give you a couple of examples. The biggest one that I've seen over the years is sleep aids. I can't tell you how many times I've had a 60-year-old, late 50-year-old come into my office with memory problems, and without even going through their history, I'll say, when did you start your sleep aid? When did you start the Ambien? And many times, especially for women, as they start to enter menopause, they might have sleep issues, and they should. This is a major crisis. This could be one of the biggest physiological crisis that a female experiences in their entire life. They literally become a different person through menopause. And in so doing, the body goes into a crisis state of a sympathetic response. It naturally has hard time sleeping. The immediate response is to address that behavior with a sleep aid. But nobody ever asked the question, what's my exit strategy? What's my exit strategy? I was on and so what happens is that individual just keeps taking these things for their entire life. The problem in doing that is that you're not addressing the true underlying problem, which is an autonomic nervous system that's out of balance. And also things like statins, which you come in and you have higher cholesterol, which, yes, that needs to be examined, but there's uh, more realistic or better medicine beyond just giving somebody a statin. There's things to look at that, yes, traditionally that may be the way you go, but ultimately over time it can have some impact on memory functioning. So these are some rule outs, things to pay attention to, and the big one on sleep. Okay, so assessment is big, and I just put up here to your right, these are the tests, an example of the test that I have done over the years, these types of tests for screening or measuring for cognitive impairment. Unfortunately, I would say that only about 3 to 4% of the population that get diagnosed with a cognitive disorder ever see any of these highly validated, important tests to truly quantify their memory issues. These tests can take anywhere from 2 to 8 hours. Sometimes we'd have to do this with over 2 to 3 days with people, but these tests are super helpful for us figuring out the overall general intellectual functioning, their attention and processing speed, visual, spatial, learning and memory, motor functioning, executive functioning. So you remember those disorders we saw at the beginning, they all, something like a frontotemporal lobe dementia has a different presentation than an Alzheimer's dementia or a type of dementia brought on from substance abuse. And so you really have to tease this out and figure out what is it that we're really going after. And that's not something that you're going to do in a 15, 20-minute screen at your doctor's office. It's got to be something that you really look at. Where are the strengths and weaknesses? So let me give you an example. I had an opportunity a number of years ago to work with an highly influential attorney. Many people would know who this person is. Highly influential attorney. And he was now getting older and he was starting to have memory problems. His graduate of an Ivy League school that we would all know the name of, okay, was in the highest honors that you could imagine through his educational and also professionally. He was honored in so many ways. And he started to have some memory problems in his 70s. So he went to the local hospital and got a basic assessment. And in that assessment, they came back and said, you're not having, any form of dementia. So let me tell you how they went ahead and looked at that. So do you guys know what a bell curve looks like? That's an awful bell curve because my right doesn't look like the left. But a bell curve is our ability to kind of see, where people fall in relation to the population. Okay. You guys have seen this, and you do what's called a standard deviation. Okay. And in IQ testing, that is a average of 100. So the average IQ in our population across the board is 100. That's the average. That's the middle. Then you work in a standard deviation of 15. So 115 to 85 gives you a range of what that's called plus or minus a standard deviation. That pretty much accounts for 70% of the population is going to get an IQ between 85 and 115. And then if you go another 15 points, you're now 2 standard deviations, okay? And so now anybody above a 130 would be considered gifted, okay? They would probably need a different type of education in elementary school and high school and college to just to keep them interested because their IQ is so high and they're in a very small percentile. And then 70 is the cutoff we use for special education, okay? Significant cognitive impairment is below 70, and they need special teachers that are trained in how to deal with this population, special ed. So you guys tracking with me? Okay, so back to my story. This guy comes in, his wife brings in the report, and they say he doesn't have any dementia. And in our cognitive screening, he came up with an IQ score that was a 100. So he doesn't have any impairment. Now, if you guys think with me for a second, and you can type this in, what about that doesn't make sense to you? That this person came up with an IQ, an average, because he was in the average range, then he wasn't having any cognitive impairment because he had showed 100 IQ. Does anybody, can you text, do it in the chat something? What about that as a clinician, as you're learning now about these things, what about that doesn't make sense for you? Which kind of for me went, what? He doesn't have a cognitive issue because he's average. Okay, let me see what this person said. Yes, excellent. His initial IQ was higher first, and we don't know that for sure, but I can tell you that where my IQ falls, and I'm not going to an Ivy League school as a world-renowned attorney that's taken on the most difficult cases. And the only type of person that's going to do that is somebody with an IQ that's up in this range. So we didn't have his pre-morbid functioning. And that's so important in cognitive disorders. It is so important that you have a baseline. I was able to come back and say, there's no way this person is an average IQ guy. Something has happened, but the system was going to just let him pass through because they weren't really thinking through average is not good for this guy. It might be good for somebody else, but for this guy, no. And so that brings me to the point where I want us to really think about when I say our number 2 thing here is assessments, okay? That the biggest thing that I want you to take home is you have to have a baseline, okay? Our culture is obsessed obsessed with colonoscopies by the time you're 50, and now it's 40. It's like you've got to get this colonoscopy. We've got people, high level athletes and people get your colonoscopy. And is that important? Yeah, it is important. But statistically, memory impairment and cognitive disorders and a baseline of your cognitive impairment so that you have something to measure should your cognition change. Is it with age or is it with a disorder? If you don't have that baseline, you don't have any way to compare. And there's things that you can pick up, even in our EEGs, in your 30s, 40s, and 50s that will let us know something might be coming down the pike. And what's truly missing across our population is getting a baseline when you're healthy, getting some of your IQ and other memory things assessed. And that's something we do and other people do. It's called neuropsych testing, to really have that in your back pocket. So in case something happens, you can refer back to it and not just guess. Now, this guy was fortunate because his history predisposed him that he's not 100 IQ. Something's going on. But we need these baselines, and it's a strong challenge to you is to think about people around you, yourself, and getting these baselines. And then you need that comparative approach. So somebody is starting to have a cognitive issue, rather than just immediately go with a screen and move on to some type of medicine or whatever. You need to get that. If you're noticing that, if you haven't had the baseline, the first thing to get is that neuropsych. So we now have something to compare to if there's a degenerative thing going on that we can look back on. Super, super important. And then those assessments, EEG assessments, neuropsych assessments, help us guide treatment. It's in a different arena, but well, no, it's in the same arena. I have a individual, an adult who has some cognitive impairment related to a developmental disorder, to autism. And we use the EEG. I've done this with many autistic individuals who can't communicate things to us about treatment, but I can use the EEG to say, yes, that's medicine is helping move the brain in the right direction, or it's not helping. And so the thing about good assessment is it guides your treatment. You're not just shooting in the dark. It's what I tell people. It's our ultimate GPS, whether that's neuropsych testing or whether that's baseline EEG, which measures the brain. And those of you that are doing neuro training, you don't realize it, but you're getting that every day. Every time you do assessment, we're getting more baselines, more comparative analysis that goes beyond treatment. Okay, so prevention, as we kind of wind down, is I'm going to say my phrase here is invest in your 401z. Okay, not your 401k, but your 401z, which is your long-term investment. So if you remember from the picture earlier, I mentioned this thing called the hippocampus, which is where your memories are stored. And in the Alzheimer brain, it was shriveled up, and in the healthy brain, it was nice and plump. Okay. That is where you're storing your long-term memories. And the number one creator of those long-term memories is your REM sleep, rapid eye movement. And the problems with some of the different medicines that we take is it can disrupt REM. Yes, you remember what we talked about earlier? I might be downstream tranquilizing you to sleep, but I'm allowing you to jump into REM like you need to, that will invest in your 401z. Okay. There's no such thing, for those of you out there, there's no such thing as a 401z. That's just kind of a play on terms. So don't go try to invest in a true 401z because they don't exist. But we want you to invest in your sleep. You need to become a stellar sleeper. Best investment for your brain's health in the future is sleep. And we can measure that sleep for you so you can see how good your REM is. And that's what you want to stay ahead of. Okay. If we were talking about the body and cardiovascular things and immune systems, we'd be talking about the deep sleep and how to invest in that. But for the brain, cognitive disorders, it's all about REM sleep. And you should know You should know what your current percentage of sleep is REM. You will not get that from your Fitbit, your Whoop, whatever, your Aura Ring. It's not going to give you an accurate representation. You need a baseline sleep study to do that. And either through us or somebody else, you need to get that, especially early on. Um, we can do those for as little as $250. We can give you a complete sleep architecture that measures all the different electrical activity in the brain and exactly what your REM sleep is. Okay. The next thing is become an anti-inflammation champion. Okay. The thing that we know about dementia, cognitive disorders, is there's a neuroinflammation that occurs. It's very clear. It's obvious in Alzheimer's and other forms of dementia that the brain has a hard time flushing toxins out because it's inflamed. And so we need to become anti-inflammation champions. Omega 3s over 2,000 units, super important. Infrared light through something like a Violight is super helpful for that. Uh, Hyperbaric chamber, boom, huge for anti-inflammation. Dietary things, very important. Watching your balance between omega-6 and omega-3 is really, really important. And one of the things that we're tracking is even really high-end stuff like looking at stem cell and how that can impact that. But you have to always be thinking for prevention, anti-inflammation all the time. And then you want to be developing a multimodal resilience in so many different areas of your life. Go through different areas of your life and give it a rating of 1 to 10. How resilient are you in that area of your life? And be working on that, because that all feeds into inflammation and stress and sleep and things that can cause problems with our brain. So by that, I mean, look at how you're doing in work, and how is that making you stronger, or is that tearing you down? 0 to 10, with 10 being the best. How are you doing in relationships? 0 to 10. How are you doing in your diet? 0 to 10. How are you doing in your sleep? How are you doing with things like probiotics and pre, and looking at those things and developing those, looking at different supplements? How are you doing in that area? How are you doing in measuring things? So look at all the different areas of your life, not just one area, and say, am I developing resilience, or am I just hanging on? Okay. And the last part, and we'll finish with this, is train your brain. You only get one brain, and keep your brain strong. I mentioned earlier that through the neuro side of what we do, that we're looking at the brain and able to measure it all the time, but we're training it. And I want to finish with this. This was a study from 2013, March 26, 2013. And this is neurofeedback. That's what many of you are doing, or you're getting close to transitioning into the neurofeedback phase. Okay. This is a study over 3 months of doing neurofeedback training. Okay, no medicine, nothing like that, but literally using the learning process to change the brain. And in brain scans, looking at the volume of gray matter, which is more your storage of memories and facts and learning, and white matter, which is kind of the telephone lines, because we don't use telephone lines anymore, but wires that connect all these learning pockets. So the gray is learning and memory, and the white is all the communication points, right? And that's when we saw that picture earlier. Do you guys remember I pointed out, look how small the white matter was in the brain? You would also see that with gray matter. Okay, see the surface area of the brain, this is kind of a flashback, is if you remember what a newspaper was, okay, imagine opening a big newspaper, full up newspaper. That is the surface area of the brain, okay? It's this big, but it has all these little nuances and crevices in it that if you stretched it out, it creates this surface area about the size of a 2 full page of a newspaper. that consists of all this gray and white matter that have the communication lines and the memory centers within them. Just doing neurofeedback increases the volume of white matter and gray matter, which is crazy to think about that. But the way it does that is by promoting more communication between these, so it exercises those communication channels. So very important. There's other things to be doing, yes, but over 35 years, this is the thing that I would say would be the most preventative thing that you would see. Okay, so thanks for your time. I went a little bit longer today, but this is a really important topic, and maybe you have somebody that you'd want to share it with. I am wondering if there was any other questions that came up. There's so much we could talk about for hours on this topic, but anything else that you would like to address before we kind of finish up here? You can send a question through the chat. You have the chat window, which is the
Well, I had an interesting question if I could do it.
sure. Where are you, James?
Do you all prefer chat or do you prefer
Oh
audio?
no, you can talk audio, James.
Oh, okay. When you were talking about the hyperbaric chamber, I had been looking into that one before, and it seemed like to me there's differences. There's like a low saturation one, I guess, where the oxygen content may not be as high versus like a more higher end one. So does that matter if it's
Absolutely.
a lower
Yeah.
saturated one?
Yeah. Unfortunately, James, it does matter. And we
Okay.
the soft-sided ones, and they come in different.
Yeah, it's like you can lay them on the floor.
Yeah. We would really love if those worked as well. They do in kind of a smaller level, but you don't get the full impact that a hard cased, hyperbaric, which you're not going to have one at your house. I only know
Yeah, I
two
mean, that'd
two
be like in
people in
the
my life that,
submarine.
yeah, they're about half a million or something to have one. Um, but there are good functional medicine docs that invest in those things, that um, when you use them, they can be super helpful. Actually, there was a really cool study that came out recently about the combination of hard-sided hyperbaric chamber and neurofeedback, and what it did
Hmm,
cognitively to the brain and make it stronger. And I should also say, this is a little side thing. You got me thinking about this, James. Um, but in the early 90s, there was a study done of pre and post IQ with neurofeedback and biofeedback combined, where increases of 15 to 20 points in IQ occurred, which
wow.
normally you think your IQ is fully fixed, but because of what we know now about gray matter and white matter, that the brain can actually not just deteriorate in it, but it can actually grow in it, that would make sense why the cognitive functioning. But you got to be careful in the hyperbaric. I do have a doctor that I work with, a functional medicine doctor, who's actually on um, our board, our medical review board that we use. His name's Dr. Bentley, and he is the expert in hyperbaric. And so I'll usually, if somebody's got a question about a certain type of unit, I'll send it over to him, and he doesn't even usually have to look it up. He knows these things so well. He'll say, well, that valve isn't the right valve, blah, blah, blah. So, um,
Okay.
so let us know, and we can kind of track that down for you.
Okay.
Um,
I mean, I just wanted to, because I'd seen like some of these pop-up places,
yeah.
they'll give you IVs and all this stuff and and it's like, well, are the devices they're offering, really that good, or is it just like what you talked about? And it's like, yeah, it sounds like I better avoid it. So,
Um, Not avoid so much as research it out, and like find out, well, what hyperbaric chamber are you using, and then run that through an expert who knows that, which we have access to, so we could help you answer that question. But there are things
Okay.
about hyperbaric that are great. The same thing about stem cell. IV stem cell is really good, but then there's a lot of places that kind of hack that and say they're doing stem cell and they're giving you, 1,000 stem cell when you really should be getting a couple million stem cell. So that's not, always going to be the same thing. Okay.
Right. Right.
Okay. Thank you everybody for attending. And hopefully this is helpful for you. If you want a book, put it in the chat. If you know that's somebody that would like maybe to hear this lecture or learn more about this, just let us know and we can send the recording out. Okay? Thank you, everybody. Great seeing y'all.
Thank you.